और कोई भी कंप्यूटर टाइप स्टार्ट करना सर ही आ जाएगा। हाँ, सर बोल रहे हैं कि कोई कंसल्टेंट आ जाए तो क्या? ठीक है ना, रिकॉर्ड हो रहा है। हाँ, हम लोग क्लोज करते हैं। हाँ, इस साइड। ठीक। सुमित सुमित मेहता सर एसोसिएट हो गया ना? एसोसिएट है ना मेहता सर? यार देखो कोई नहीं आया क्या? नहीं, सर ने बोला कोई कंसल्टेंट तो आए। सर आएंगे 5। हाँ, लेकिन टाइम हो जा रहा है तो हाँ, शुरू सर तो आएंगे 5, थोड़ा लेट आएंगे, लेकिन सर ने बोला कोई भी कंसल्टेंट आ जाए तो उसका टाइम। अभी सर को आने दो, सर को आने दो ना। हाँ सर को आने दो, सर आए नहीं, थोड़ा सा रुक जाइए, सर को आने दीजिए, है ना। अच्छा, गर्म करो। Let's start. So, good morning, everyone. The topic that I've been given these days, polysomnography. Considering it as a huge subject, I've just managed to give and tried to manage to give an outline, a very brief outline, ultra brief outline regarding this. I'll go through 35 slides in my whole presentation. And my moderator is Dr. Smith Mehta sir, and I'll be presenting it. And first I'll go through some history, then components and certain indications, and you'll see the illustrations later on. So considering the history of polysomnography, as we all know that Caton had discovered brainwave activity in primates, mostly in primates, in around 18, a long time, in 75, he used live primates for this. Loomis had discovered the first continuous internal cause continuous overnight EEG in 37, and the combined use of electroencephalogram, electroaculogram, and electromyogram to determine the various behavioral states in different stages of sleep and wakefulness had been credited to Krickman, Aselensky, and Dement. Obviously, when you have such a subject called polysomnography, you need to have a manual for standard guidelines. The first manual, popularly known as RNK manual, the Reschaffen and Kells manual, was designed in 1968. The term polysomnography had been coined by Jerome Holland, William Dement, and Renal in 1974. Recently, in the after the turning of the century, in 2007, the American Association of Sleep Medicine has taken over and is being publishing standardized manuals. I think the second or second manual has been created till now for the PSG guidelines. Now, so coming to the components of the PSG. So as in EEG, what we do, you all know, we follow the standard 1020 international system, right? So if I give a very simple pictorial diagram, it will be like the concept is that the frontal, central, and occipital loads electrodes would be paired against the opposite mass spectrum. So it would be standardized system says that the right side is even number, left side is odd number. So the F4, C4, and O2 to be paired against M1. That is the recommended thing. But backup is always there. It's the opposite side, F3, M2, C3, M2, and O1, M2. You can understand by the figure. I don't have a laser, but this figure you can understand that this side has been paired to the opposite mastoid. And if this is absent or this is malfunctioning, we can always pair it with the other side. Okay. Right. So right. This one is okay. Thanks. So this is the recommended thing. But then again, if we miss this, we always have the other side. So this is often in the cases. These are the standard electrodes. You have seen it in your lab also being used there, and this jelly. So we use it during. Now the other components after the EEG comes chin EMG. So the chin EMG position would be more like this, which would be one electrode would be Z electrode would be 1 centimeter above the chin, and the other two will be 2 centimeter below and 2 centimeter lateral, both sides. So these will be the 3 electrodes which will be governing the chin electromuscular activity, right? Why is this chin very important? Because of the increased muscle tone or the decreased muscle tone during this sleep, which can be regulated. In bruxism, you see some increased muscle tone, right? So this is just examples again. For the electrooculogram, which is there, standardized is again this. Okay, there will be 2 electrodes, 1 centimeter lateral and 1 centimeter up, 1 centimeter lateral and 1 centimeter down. Okay, so this will be the E1 and the E2 electrodes. This is the standard, 1 up and 1 down. However, there is an acceptable variation also, which is both down. But this is mostly used, but conjugate eye movements are best seen in this setting. Okay, now going to the leg EMG, mainly used for the collection of data for limb movements. Okay, so there are these 2 electrodes mostly over the anterior tibialis muscle, the belly of the anterior tibialis muscle, 2 to 3 centimeters apart, and we generally do it like So the ECG electrodes, the very standard ECG electrode is being given. The negative electrode is placed just below the right clavicle, as you have seen, and the standard positive electrode is placed in the 6th or 7th in left dorsal place on the midline of the patient's left side. There is another alternative, but rarely used. This and this are generally used. Now, these 2 are very important. These bands, the thoracic band governing the expansion of the chest, and the abdominal band governing the expansion of abdomen. So these 2 will indicate how much respiratory effort is being given. How much respiratory effort is being given by the person. So the thoracic gland would be placed mostly under the armpits, just below the nipple line, and in females it will be above the nipple line, and the abdominal bands will be placed just above the hips at the umbilical level. Okay. The band needs to be firm enough to expand and contract the patient's breathing, yet loose enough for comfort. Now, it's a very fine line. Nowadays, fixed bands are available. Earlier, you used to cut we had new bands, and you have to cut it with the measurements. There would be standard measurements for it. But now, fixed bands are available, which are adjusted. In the nose, there was actually 2 things, nasal thermistor and nasal cannula. So, the nasal thermistor actually measures the temperature of the airflow that is coming out or going. Okay. And nasal cannula measures the airflow per se. It measures the volume. Now, both actually measure how much air is going out and going in, but often nasal thermistor is not so capable of determining the difference between hypoapnea and apnea, because hypoapnea is basically some diminution in the volume of air which is being expelled, which is some diminution in the apneic breathing effort. And apnea is total diminution in breathing efforts. But since both the air is coming out as warm, it cannot measure the temperature difference there. That's when nasal cannula comes into the picture. It can measure the exact volume of the air coming. Now then it will give the way whether it is 90% or is it 30%. Okay. Tracheal sound sensor will give you the snoring sounds, which will mostly coincide with the apneic or the hypopneic levels. So this will be the nasal cannula that is attached, and this is the nasal thermistor. I think here the difference is not being seen. The nasal thermistor is more of a flat thing, which is going under the nose. Nasal cannula is a cylindrical thing, which measures the airflow. And this is the tracheal sound sensor, which is kept here as it is kept like this. The pulse oximetry, you all know, you have seen it in your own ward. This is the pulse oximetry, which is placed in the finger, and alternative sides are toe or yellow, but generally we use the finger with this. Along with this, the PSG room, which is a separate room from the recording. If we suppose that this is the PSG room, then our monitoring room will be just opposite to this. And this PSG room will be fitted with this speaker and the voice box, basically the voice box and the video, as we see in the video EEG. So there will be video, continuous video monitoring. and that the whole feedback will be going to that room. And we can actually hold a mic and tell the patient what to do, because that is important in calibration. While biocalibration is a separate thing, we have to train the patient for some leg movements and other breathing efforts. So for that, those connections are required. So video recording and speaker systems are required in a PhD. So one, if I can show you all these things when they are combined. So yesterday only I got this picture. The person's PhD was being done. I could not get the whole picture. The leg electrodes are not being shown here, and the oximetry is not being shown here. Looks very cumbersome. Looks very cumbersome, and like how the person will be able to sleep. That is our first concern. How the person can sleep in this manner, but the person sleeps within 3 minutes. So how does it occur? Basically, the persons who are sleeping here are mostly obstructive sleep apnea patients. And in obstructive sleep apnea patients, you usually have a very decreased latency, sleep latency. So sleep comes on very easily. Even while sitting, they can sleep. So that's why they sleep very easily. But the insomnia patients find it very difficult. Who have comorbid insomnia find it very difficult to sleep here. And also the first night effects. Okay. This is the monitoring room, as I told you. The recording room is that one, and this is the monitoring room just opposite. Okay, and we'll have one system for the PSG, one system for analyzing data, and there will be another system for activity. Activity is a separate thing, but for this, at least 2 systems are for PSG monitoring. Now coming to the indications for polysomnography. Main is again the diagnosis of sleep-related breathing disorders is the primary indication and the most common indication that has been used in PSG. Corollarily, we can go that neuromuscular disorders, patients who have neuromuscular disorders and sleep complaints, that they can also be investigated. CPAP and BiPAP titration obviously a part of therapy of obstructive sleep apnea for CPAP and BiPAP titration. Evaluation of response to such positive airway pressure, for that PSG is required. Before surgery, before upper airway surgery of snoring or of OSA, surgery has actually been quite demonized in the recent times. When CPAP has arrived, the positive airway pressure has arrived, surgery has been mostly not been the hot topic for pulmonologists. The surgery people always say, okay, the surgery should be done, but the rehabilitation is very difficult. Again, evaluating response after surgery, everything will have to be gone through a PSG testing. Okay. Diagnosis of narcolepsy, which is basically multiple sleep latency test, which will follow the PSG. Nocturnal epilepsy, as we get the EEG waves. Obviously, EEG will also do, but since often nocturnal epilepsy is combined or maybe confused with parasomnias, so that's why this is very important. REM sleep behavioral disorders, periodic limb movement disorder. One thing I have kept in a bit greater fonts, larger fonts, is insomnia. Generally, insomnia is not, the PSG is not a very good diagnostic procedure for insomnia. Insomnia only if there is a suspected comorbid disorder like all this. But generally, for insomnia, PSG is not diagnostic test. So maybe in PSG, what is very important, what are not the indications of PSG? That is very important. Not every sleep disorder has to go through a PSG. Okay. So what are not important is patients who have been adequately treated don't require any follow-up PSG. Seizure disorders that are mostly daytime, not required. Restless leg syndrome, total clinical diagnosis. We don't require PSG at all. Insomnia, most insomnia disorders do not require PSG, only if there is a secondary comorbid breathing disorder or any other disorder which I mentioned earlier, only those require, otherwise no. Circadian rhythm disorders, as I told you in the rounds, advanced sleep-wake phase disorder, delayed sleep-wake phase disorder, or mixed sleep-wake phase, irregular sleep-wake phase disorders, all those do not require PSG. So these are very important, which do not require. Okay. Common things like nightmares, bruxism, although I told you that bruxism is often got in the chin EMG, but for diagnosing that is not required. Diagnostic entity is not required. Okay. Now, a brief outline of the most common indication, as I told you, obstructive sleep apnea, hypopnea syndrome. That's OSA-HS, right? So let us go about 5 or 6 slides with that. So the pathophysiology is mostly very simple. While the patient is lying down, we can see this soft palate, uvula, and the laryngeal muscles. So the air is going in very easily. Now, if these muscles have a bit of hypertrophy or fat deposition is there, or the muscles are reclining, then we have this decreased airway. Now, when you have this decreased airway, these muscles flap around when the air goes in. This which leads to snoring, obviously. Now, when there is a complete obstruction in this airway, it leads to apneas and hypopneas. In the previous what do I say, pathology, and apnea in the ultimate pathology, right? And here we can actually find our importance for the orofacial examination that we do. If we have a retrographic person, the muscles here would be more probably would be reclining backwards. If we have someone who has this submental fat deposition, again the muscles would be pushed back here. So that is the importance of our orofacial examination in obstructive sleep apnea. Okay, now yeah, this is the very brief pathology of OSA. So it is again very simple. There is a neural control of our breathing. There is a muscular control of our breathing. And while the sleep onset is there, we have this loss of neuromuscular compensation. So the tone of the muscles which was being maintained in the awake state. In the awake state, the patient doesn't snore usually. It is being maintained in the awake state. The muscles are being pulled up. Now, when you sleep, the tone will gradually reduce and the muscles will relax, and then they will be pushed in that side, and then the airway will collapse. We have this collapse of air leading to apnea, hypoxia, obviously, hypercapnia, and then the increased ventilatory effort will come. Whenever there is increased ventilatory effort, the arousal will be there. Microarousals or macroarousals will be there, and then the person will wake up. Pharyngeal muscle activity will be restored. Tone will again catch up, and then will feel much more relaxed. And the hypercapnic and hypoxia and hypercapnia will be restored. So this is the usual cycle. Now, if we compare this usual cycle, it brings us to the symptoms of obstructive sleep apnea. Frequent nocturnal awakenings, and person feeling suffocated during sleep. All these things will happen due to this pathology, right? And this is where we'll strike with our positive behavior. Okay, so obviously OSA has a multi-pronged effect: cardiac effects, renal effects, effect on the fat cells, everything. Now, generally, what we see in obstructive sleep apnea, we have this chronic intermittent hypoxia. So, chronic intermittent hypoxia leads to the activation of the RAS system, renin-angiotensin system. Obviously, renin-angiotensin system, they will then again go in favor of retaining water and all these things. They will go in favor of disturbing the aldosterone mechanism. All these things will happen and ultimately lead to a systemic hypertension or aggravation of the pre-existing systemic hypertension, leading to kidney changes, to pathological changes of kidney. Here there are cardiac changes. As you can see, it also leads to increased sympathetic activity, increased catecholamines, which leads to our increased heart rate, increased BP, endothelial dysfunction, all these things leading to hypertension. Again, the decreased oxygen, the increased the hypercapnia and the hypoxia, they will disturb the myocardial oxygen delivery anytime. They will disturb it anytime, and which will lead to other cardiac pathologies like ischemia, arrhythmia, not directly, but there are many mechanisms. This is a very brief thing, many mechanisms indirectly. Okay. The macrostructure of the cardiac wall will be disturbed. The circulating hormones and the catecholamines, they will be disturbed. All these things leading to a increased BP, increased let's say work pressure for the cardiac muscle, which may lead to cardiac arrhythmias in an already